Very pleased to be here today to kick off this innovative and exciting conference. And I'm particularly pleased to be able to speak first. And this is important for two reasons. Firstly, because if I speak first, I get it over with and I get to relax and enjoy the coffee break. It's not quite the same for those poor people speaking afterwards. So that's the first reason. The second reason, more important, is that patients rarely get to speak first. If they get to speak at all, they're usually put at the end, usually asked to contribute after everyone else. Had an experience of that last week. I don't do much of this kind of speaking, it's quite new to me, but I was representing patients involved in research at a meeting in Germany. And they said, oh, would you like to talk about what you're doing in this research? And I said, oh, great. And we got together all the other patients from countries and we put something together. And then we looked at where we were put. It was a 2-day conference. It finished on the Tuesday at 5 o'clock. People were getting flights to go away. What time do you think the patients were put at? 4 o'clock would have been good. It was 4:30. We did actually get it changed, and in fact, by changing, we got a very good slot. We got it just before lunch, when people were receptive, and there had been talk of an alcoholic cocktail, so people were doubly receptive. So in the end, it worked out. But quite often, patients don't get to speak first. And I can't stress how important that is, and it's something I'll come back to. But of course, although we're thinking here about patients first, patients are quite often used to be patients first. The trouble is they're also used to be patients last, and they're used to being seen as patients at every stage in between. What they're often not seen as, of course, is people. So what I want to share with you today is some insights from 30 years of living with first one chronic illness and then being greedy and collecting a few more, and also the work that I've done for Arthritis Research UK over the last few years. To try and marry up, how do you put patients at the centre? How do you put them first without forgetting that they are also people first? Now, when I was asked to talk today, part of the brief was, well, just say what it's like to live with chronic illness. And I thought, it's a bit hard, that one. And I thought about it for people who've never experienced it. And this is what I came up with. It's a bit like a game. It's a bit like a kind of strategy game. So if we start in the corner here, if we start with 1, that would be me, diagnosed at 26, severe onset rheumatoid arthritis. I was in a new city, in a new job, in a shared house, very little money, not entitled to sick pay, and I ended up in hospital, initially for 7 weeks. And that was the beginning of a lot of time in hospital. And so my goal, if you like, to get to 100 would be to get to a point over the years where if I didn't get a cure, at least I would get things which would manage my symptoms enough to enable me to have a good quality of life, to be able to do some of the things that I'd hoped to do when I was 25, before my life changed. And that should be simple, because after all, I've got all you great people working away on my behalf, beavering away, getting new medical treatments, funding research. And indeed, most of the ladders there have come from medical research. So let's just mention a couple of these ladders. I was lucky enough to get seen early. I was lucky enough to get admitted to hospital, and I was lucky enough to get under a consultant who, guess what, was doing a big research study in early onset rheumatoid arthritis. It wasn't the first thing on my mind, but it meant that I got a lot of very good clinical treatment. A big ladder. That's continued. over the years, every time things have looked a bit desperate and I've had to come off one drug, there's been another one in the pipeline. Drugs funded by the charity that I'm here representing today. And if I could pick out two of these, a drug I was given 9 years ago, biologics, absolutely transformed my life. If I can pick out another one, I also suffer from something called antiphospholipid syndrome. That means that my blood clots. It's an issue when I was pregnant, desperately wanted children, kept miscarrying. Eventually, diagnosis and treatment. Treatment, again, research into the effectiveness of which had been funded by Arthritis Research UK. So it's partly why I'm volunteering for them, because they have, their research funded by them has quite literally transformed my life, and it's helped me get up towards that magical 100. So medical research is great. However, the problem with a lot of medical research is it focuses on the clinical. It focuses on looking for a cure, and it focuses on relieving clinical symptoms. The trouble is, while you're waiting for that cure, you have a life to get on with. And what I soon realized was that there were a lot of snakes going to push me down those ladders, and most of these snakes were not going to be addressed by clinical effectiveness. There's a lot I could mention. I'll mention one. When I was first in hospital, I was in hospital for 7 weeks, and I had fantastic treatment, and then it was time to go, and I thought, great. I was very excited. They'd patched me up. I was bursting with steroids, had lots of energy. I got my party bag, my leaving bag. Well, I had the usual. I had drugs. But my party bag was quite big, because I also had huge plaster cast splints with Velcro straps. This was back in the 80s when they did things like this. And I was supposed to lie in these at night. You can see some people smiling with recognition. And I was supposed to wear them during the day sometimes, just for a couple of hours. Now, I didn't have any money, wasn't entitled to sick pay, I needed to work. So this was a bit of a problem. Thrown into my party bag were the kind of ubiquitous splints that patients get, what can only be described as gruel-coloured, not quite made it into any paint chart. And then something as well, because I had arthritis of the jaw, called mouth expanders. And I'm going to leave that one for you to Google and have a bit of fun with later on. So this was what I was leaving with. And remember, I was 26. I wasn't in a relationship, but I was ever hopeful. And so I thought, well, I've got to ask the question. So I said to all these people I'd built up a good relationship with, well, what about sex? Is that now out of the question? The silence continued for about 5 minutes. Everyone looked at the floor, and I thought, oh dear, I've said the wrong thing. And when you're a patient, you often feel quite nervous because these people have got responsibility for your life. So I thought, I better not mention that again. And that was my first experience of being silenced, of certain areas that simply are not talked about. And why might that be important? I'll tell you, chronic illness desexes you. It makes you feel quite unattractive. Your body's poked and prodded around. You're in pain a lot of the time. You suffer all kinds of indignities. Anything that can be positive, can make you feel positive about your body and help you sustain normal relationships is important. I'll share something with you. 2 weeks ago, I was in a dermatology clinic at Salford Royal because by now I've also developed psoriasis, partly as a result of one of the drugs I take. And I was filling in the usual questionnaires. And there was a question about sex. How is this affecting your physical relationship? And I was so happy to see that question. But it had taken 30 years for that question to be there in a questionnaire for me. So those are the kind of snakes that I'm referring to, things which affect my life, affect how I deal with the disease, and are not really talked about. I'm going to mention one more snake, comorbidity. Now, there's a nice term. Patients don't usually use that term. Patients usually say, someone up there is really taking the piss now. I started with one condition in my 20s, I got another one in my 30s, another one in my 40s, and then I think I'm doing all right. Haven't had one for the beginning of my 50s, I got psoriasis. I've also lived with depression and anxiety. No wonder. If you have those conditions, you do. And we know that comorbidity is a real problem for many patients. We know it's on the increase. And yet we have, in the healthcare system, still a single model of treatment. So you get treated by one consultant in one hospital for one disease, and then you run down the road, or in my case, you go to several health authorities because I live in a big city and I am under South Manchester, I'm under Salford, and until recently I was under East Cheshire. They don't even use the same blood tests to measure inflammation in two of these. So you're constantly joining up the dots in this system. That's a very, very big snake. The system itself can be a very big snake. There's this phrase some of you may remember from a comedy program, the computer says no. Anyone who deals with the system, anyone who's a carer, will recognize that. Everybody's willing to help, but if you try and change an appointment, if you phone up because things have gone missing, if you phone up to find out why you've been on the waiting list 6 months, it's always the computer's fault. And the computer doesn't know me, and I have no control over that computer. I'll give you a good example. Computer generates automatic letters. So if I missed an appointment for a very good reason, it would generate a letter. If I missed 2, it would generate a letter saying, we're going to discharge you. Sometimes I haven't missed those appointments. Quite often they've been cancelled by the hospital. Sometimes I've even had a rescheduling letter arrive in the post before the cancellation, which can be quite confusing. But patients will get the letters saying, oh dear, go back to number 19. You've missed appointments. And they will panic. And when they phone up, people will generally say, oh, no, 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 no. It's okay, it was a mistake. It was the computer. This is the system that can be quite stressful to deal with. It's not a huge thing, but it's a daily drip, drip, drip that can really have an effect on you when you're ill. And I sometimes wonder, what excuse could I give that would allow them to rearrange an appointment? And I have quite a rich fantasy life, because if you sit in waiting rooms a lot, you do. So I go through in my head, well, no, this hasn't worked. The most recent one I've thought about suggesting was, I'm in a hostage situation. I'm sorry, I can't make it later today. I'm in a hostage situation. If I get out alive, I'll be there. But if not, I'm sorry. And I just imagine this woman saying, well, I'm sorry about that, but the computer doesn't have a code for a hostage situation. So I hope you get out alive. And if you do, I'm afraid you'll have to go back down the list again to number 15. So this is the system. And if you're a patient, it can be very wearing. But let's be more positive. Involvement with research. When I was 47, 48, I'd had to give up work. I was an academic, I was a teacher. And my health was much better, but I really felt a lack of intellectual engagement. And I saw this advert to be involved with Arthritis Research UK. And what was great about this advert was that they wanted sick people. And I thought, this is fantastic. Sorry, that's just moved automatically. They want sick people. And I had been spending a lot of time hiding my illness, particularly at work. So here were people saying, come on, you've got more than one illness, great, that's even better. So that started my journey as a patient involved in research. And it has been fantastic. It's been fantastically empowering for me. And I hope that what I do benefits research. Because we know if patients are taken seriously, and this poor guy, unfortunately, is the token patient. You may have come across the token patient. They're invited to meetings. It's a bit of a tick box, but nobody actually wants them to speak. But if it's done properly, and you let the patient speak, then it can be fantastic. Patients benefit. I felt empowered for the first time in a long time when I got involved in research. Hugely beneficial. And we know that research benefits. We know that involving patients in research makes for better outcomes. The methodology is better. Researchers are made to think about whether or not this is the right question or the important question. You add all kinds of extra benefit to evaluating clinical studies because you've got real-world experience to complement clinical trials. We know that it works for everyone. We also know that patients add value for money. However, what I want to stress is that I think patients in research is also the ethical thing to do. And I also think that it should be a democratic principle. We live in a democratic society. If we are using patients in research, and if we are developing things which we're going to give to patients, then it is only right that patients have a say in how the research is done and what kind of research is done. So we know it benefits everyone, but I think hang on to not just the value for money, but also the ethical principle, the democratic principle. But it has to be meaningful and not token. What is great about patients in research? We have our own expertise. It's a different one, but it's an equal one, because we live every day with understanding the effects on our everyday lives. And I'm just going to leave you with a few points, a few ways in which today you can think about small things that can make a difference in how you treat patients that you partner with and engage with. The first thing is to ensure that you include us in the conversation early on, and you've made a great start today. If patients are allowed to shape the research agenda, they can bring new insights to conventional ways of thinking. If you're last on the agenda, if you're the one lone voice in the room, it's very difficult to change anything. One patient can't talk for us all. And if I could just mention one very small thing that the charity Arthritis Research UK have done in changing how patients are used in reviewing research, it's that they always talk first in meetings. They always talk before the scientists. And I can't tell you the difference that makes. It changes the whole dynamic. It changes the nature of the conversation. It even changes the way the researchers relate to one another. It's incredibly liberating for everyone. The second point I'd make is think about accessibility in a much bigger way. When I was coming here today, I'm doing pretty well in terms of accessibility. I got sent a lot of stuff, but accessibility is not just physical. Think about psychological accessibility. How many patients are you inviting? Is there enough of a critical mass? Are patients going to feel comfortable? Think about economic accessibility. Do you charge patients? Patients should be free at conferences. Chronic illness makes you poor. We know that. So think about that. If you're using patients in research, or you're inviting patients to speak, pay expenses up front. It can be very difficult for patients in research to actually pay up front for things, or to claim for things, because they don't have the kind of infrastructure that in the workplace you might take for granted: photocopiers, scanning machines, etc. So think about economic accessibility. Think about diversity. And by this concept, I don't mean the different kinds of disease or types of illness that you have. We're all different. I can't speak for everyone. We all have different experiences. And my needs are different at different times in my life. Chronic illness affects you in different ways. And like everything else, a lot of how you experience it will depend on things such as your socioeconomic position, your gender, your ethnicity, even your sexuality. So think about that. Think about diversity. Don't try and make one patient carry the voice for everyone else. Once you've invited us to the party, don't exclude us. So try and talk to us in language that we understand. And finally, do be genuine partners with us. Don't appropriate our experience. Too often, people talk about partnering with patients in research, and too often, what they mean is, well, we'll appropriate your research, we'll tell you a story, we'll take it, we'll use it for our own agenda, and then you can go back to your cage or your bed or whatever. So try and make it genuine. We all live in a real world. We know that we have to come together with different agendas. Sometimes those agendas will work together. But think again about the ethics. Think again about the democratic principles. I'm going to finish just with one point. If you think about chronic illness, the way I think about how it affects me, it's a little bit like having an octopus inside you. You've got all these tentacles, and they grow, and all these tentacles enter every area of your life, whatever it is. And right at the middle is you, your self-esteem, your identity. And if you find me a cure tomorrow for my diseases, that will be great. I'll be happy. But it won't change all the things that those tentacles have wrapped around and twisted. It won't change what's happened to my working life. It won't change what's happened to my relationships. It won't change how I feel about myself. It won't change my socioeconomic position. So if I can ask for one thing, think about that. By all means today, think of us as patients first, but also think of us as people first. And go beyond the clinical to look at the whole person. Thank you.